Good evening. I'm Ellis Dean, your host from blackdoctor.org. Thank you for joining us for this important conversation, one that could save your life. We're back with another panel in partnership with Cedars Sinai as we discuss the latest information about lung cancer, including prevention, screening, diagnosis, and treatment, including the exciting promise of new targeted therapies for some lung cancers. Today's discussion is also available via simultaneous interpretation in Spanish on our Daily Vitamina Facebook page. We're talking about lung cancer because being Black is one of the risk factors for this disease. And because we know a diagnosis of lung cancer can be overwhelming, but thanks to available screenings and new targeted treatments, there is hope. Our expert panelists today are here to discuss the latest screening tools and treatments to give our viewers all the latest information about lung cancer. Let's talk about it. But first, let's meet our panel. Dr. Karen Reckamp is Associate Director of Clinical Research at Cedars Sinai Cancer and Director of Medical Oncology in the Department of Medicine. Good evening, Dr. Reckamp. Also, we have Dr. Sarah Gandahari. She is a pulmonary medicine specialist and medical director of the outpatient pulmonary rehabilitation and centralized lung cancer screening programs at Cedars Sinai. Dion is a longtime patient. Sorry about that. Wow, okay, you didn't see me. But Dion is a longtime patient she's a longtime patient of Dr. Reckamp who benefited from targeted therapy for her lung cancer. She's now an advocate for lung cancer awareness. She wants you to know if you have lungs, you can get lung cancer. We've got a lot to talk about today, so let's get started. So sorry about that. I was so excited to get this program started. I forgot to take off screen so y'all can see this lovely face that I have for you this evening. But I want to say thank you to all of our guests for joining. So we see Dr. Reckamp, and we'll see Dion and everybody that is here as well. So we're going to get us back on track. Good evening, everybody. Now we can see everyone. All right. All right. So the first question that we have, with regards to, can you give us, and this could be, can you give us a little background on lung cancer and how many people are affected and the types of lung cancer? So that's a lot of information, but we really want to know some background, how many people are affected and the different types of lung cancer. Because I don't think people know that there's different types of lung cancer. Anybody want to take that one?
I'm happy to take it.
Sure, Dr. Gandahari, thank you.
Thank you so much for having me here.
So I want to just make sure you can hear me.
You're a little choppy right now. There seems to be some connection issues going on because it's coming through really choppy. So, Dr. Gandahari, go ahead and take that first question, and we'll try to work through what's going on with Dr. Rick.
Thank you.
Can you hear me now?
Yes, we can, but it's still choppy. Let's go ahead and we'll work through that. Let Dr. Gandahari get going.
Sure. I'm happy to address that first question with regards to how common is lung cancer. And it's amongst both men and women, it's considered the second most common, breast cancer being the first most common cancer in women, prostate in men. So it comes as second as the most common type of cancer. However, it's very impactful because it's the cancer that actually leads to the highest number of cancer death. And so it's really important to talk about it. And one sobering statistic that comes in is that every 2.5 minutes, a person in the US is diagnosed with lung cancer. That means at the end of this hour, there's probably 24 more people that are affected by lung cancer. It's just, which is a pretty significant number. Now, this cancer is common, and there's different types of cancer. There's different phenotypes of cancer, or the way that it's presented. We look at it based on the type of cells, the way that and as it has different treatment and different presentation and different outcomes. And so there are a number of things that we think about as far as lung cancer. And the key thing about it is that the earlier we diagnose lung cancer, the better that we can address and treat it, the better that we can we have a lot more strategies and a lot more treatments that are available as far as treatment of lung cancer.
So when we're talking about lung cancer, media and marketing has done a great thing and associate. And this is very important that yes, we associate now lung cancer with smoking, but we don't think about it in any other terminology. I'm just speaking as a layperson that says, okay, we associated lung cancer, smoking, everybody else is safe. Is it primarily a smoker's disease, or can other people, get lung cancer?
And as far as lung cancer goes, majority of folks that have been diagnosed with lung cancer have been affected by cigarette smoking. However, that is not universal, meaning that we see anywhere between 15 to 20% of people who are diagnosed with lung cancer have never smoked before. And so there's a lot more to lung cancer that we're still learning. And some of the factors that impact, the getting lung cancer could be some genetic factor. If there's family history of lung cancer, there is increased risk of lung cancer that can happen in that person. Other environmental exposures, such as pollution, radon, which can be in the environment, other occupational exposure that can impact it as well. And so while cigarette smoking, if one smokes it, there's also secondhand exposure that leads to it as well. So the key thing is that while, yes, cigarette is the most common association as far as risk factor goes, it's not the only thing that causes, and we're still learning and understanding more about it.
So, all right. So we know other people can get it, and Dion, as I said in my intro, said that if you have lungs, you can get lung cancer. So, who should be getting screened, and what are some of the screening methodologies that are available to us?
As far as screening goes, it is intended for people who are at increased risk for lung cancer. And the way that this has been identified is to essentially look at those based on their age as well as their exposure to cigarette smoke. And I realize that doesn't include all the aspect that increases one's risk for lung cancer. But if somebody is between the ages of 50 to 80 years of age and they have had a significant amount of smoking history in their past, and as much as we define that is 1 pack or 20 pack year, which the way that you define it is, if you smoke 1 pack per day for 20 years, that gives you 20 pack year. And that is considered a significant amount of smoking. Now, if you smoke half a pack a year for 40 years, that also adds up to be 20 pack year, and that gives you the increased risk. And as far as if you meet the age criteria and that significant amount of smoking, and you're either actively smoking or have been smoking within the past or quit within the past 15 years, puts you at high risk, which makes you qualified for getting a screening low-dose CT scan, which essentially is a CAT scan of your lung, and it is recommended for that to be done on an annual basis to look for signs of lung cancer. Now, when you talk about screening, it is intended for a person who has absolutely no symptom, meaning that they're not experiencing any issues, they're not having any problems or signs or suggestions of lung cancer. And this is somebody who's completely otherwise healthy. They're not even thinking about lung cancer, but they have the history of smoking in their past, or they're actively smoking, and they meet the age criteria, and they should be screened, because not only we can potentially find lung cancer early, and in large studies it's been shown that it can actually save lives. It can improve the survival of the person that has gone through screening, because we can identify the cancer earlier.
Well, I think we've got Dr. Reckamp. I think we got you. You're looking clear now, so that's a good sign. So that's always a good sign. So, all right. So we talked about screenings. We talked about methodologies. Talked about smoking. So, what are those symptoms that we should be paying attention to in our body, and that we should be reporting to our doctors if we start experiencing those symptoms?
So the most interesting piece of this, and why screening is so important, is because we often don't have symptoms until the cancer has grown to a significant size. And so, again, emphasizing the importance of screening when you don't have symptoms. Symptoms for lung cancer, the first are often within the lungs themselves. And so things like shortness of breath, coughing, sometimes coughing up blood can be a symptom. And then people can have symptoms that are even outside of the lungs: pain in the bones, headaches, weakness, overall fatigue, or systemic symptoms such as loss of appetite and actual weight loss. But again, many people do not have symptoms until it has become more advanced.
Okay, so that's, I don't know, that's good and bad to know, right? So it's like you're not going to have symptoms until things start really developing, and so just kind of have to. So, and we also talked about the obvious. Okay, we know about smoking, so we're going to put smoking on the table over there. But what are the other risk factors? Is it pollution in your environment? Is it secondhand smoke? Is it hereditary? What are some of the other risk factors that can increase your risk to developing lung cancer?
So interestingly, smoking has been such a strong risk factor that we have less of an idea or less of an understanding of the secondary risk factors. Secondhand smoke definitely is a potential cause. Exposure to radon and other pollution, definitely a cause. And then there's a genetic component. And interestingly enough, people of Asian descent have higher risks of lung cancer, and especially non-smoking lung cancers. And there are family history that can indicate that there may be a genetic risk. We don't have screening for patients who have potential genetic risks at this moment in time, but we're moving in that direction. And some of the best information comes from Taiwan, where they found that lung cancer screening, even in people who didn't smoke, who have family history, may be something that can increase patient survival and increase the chance that you're diagnosed with early stage and more curable disease.
Okay, so I'm gonna talk about the elephant in the room. We're on blackdoctor.org, and so we are acutely pointed towards getting information that's culturally relevant for our audience, and our audience is primarily Black Americans. And so, is there a difference in how it's expressed in Black Americans, and how is lung cancer impacting not only Black Americans but other communities of color? You talked about Asians having risk factors.
Yeah, I will say that even the non-smoking is happening in Black people too. Non-smoking lung cancers is a higher risk in both smoking and non-smoking. And then going back to the screening piece, nobody is getting screened at the rates that they need to be screened at. California is one of the worst states for screening for lung cancer. And we can talk about all those reasons. A lot of it is the way that funding goes. But we're trying to get out into our Black communities where there are higher risks, especially in people who are smokers, and trying to get the word out about lung cancer screening. And maybe Sarah can speak a little bit more about trying to get the word out to our Black community to get better lung cancer screening.
Yeah, talking about the impact of race and on lung cancer, I think it's an important topic to talk about for several reasons. One is the outcomes are different. So when we look at survival of those who are of color, in particular, communities of color have lower survival by 20% compared to patients, other patients of white population. And so we look at the survival and wonder, what is it about lung cancer in this population that is leading to a worse survival, a worse outcome? And there are several factors. One is that we've seen that in particular, people of color are diagnosed later. So that is a huge factor, because one of the biggest thing that we see in terms of survival is how early we diagnose it. And when we see that communities of color are diagnosed later, that's the first impact that has in terms of the outcome. Then there's other aspects of, they're also not getting treated as often. They're not getting as often surgeries. They're not getting as often the treatment with in total, in general, and not getting treated at all. And so what makes it impactful in terms of when we're talking about this is that not only lung cancer impacts us in general in terms of being cancer that has the worst mortality amongst all, in communities of color, we're even seeing even worse outcome. And so there's even need to be a stronger push in getting in patients in to get screened earlier. And then there's other aspects with regards to the cigarette smoking, the type of cigarettes that are used, that are typically consumed, and the impact of how addictive they are and how difficult it is for patients that are using, for people that are using those kind of cigarettes to be able to quit, which is, we know is perhaps also the most impactful in terms of prevention to actually quitting. And so there's the aspect of it's difficult to quit. There is issue related to access as well as getting screened early on. And then when you're talking about why are we screening, why are we diagnosing late? Why are they not screened earlier? Why are they not diagnosed earlier? And there's several factors. I mean, there are patient factors, there are provider factors, and then there is whole community and health system factors that goes into it. So we, Dr. Gradka mentioned in terms of funding and availability of resources and having access in all areas is one sort of a community aspect of availability of resources. But also, as far as providers, there is the issue of, it actually takes time to go through and discuss lung cancer and lung cancer screening with patients. There's also the issue of trust of the providers and making sure that this is the right thing. And there's a lot of misinformation, or there's a lot of fear that exists related to lung cancer that prevents both patients and providers to want to talk about it. They're worried that if they're diagnosed with lung cancer, that this is a deadly disease, that they're not going to be able to, they don't have options. Whereas we actually want I want to make sure that this message is passed through, that there is actually a lot of options that are there, and that you are in the driver's seat in terms of learning about the option and seeing if these options of screening are right for you, and talk to your doctor about it. And so I think what you mentioned earlier in your intro, that being Black is actually adds a factor into this. And I think it comes into mostly related to just the aspect of getting diagnosed early more than anything else.
Well, yeah, I mean, it's sad, and so I will say that to your point, and I'm going to climb on my soapbox very briefly here for a moment, and just say, let's, as a people, as an audience, as the patient base, as representative of the patient base here, along with Dion, is that we've got to get a better handle of our family history. So we got to know who the smokers were, and we got to know if anybody in our family had lung cancer, and that risk factor. And then also B, we've got to do a better job of making sure that we're getting, if we hit those risk factors, if we're smokers ourselves, then we need to go ahead and get those screenings done, and do the follow up, and all the adherence that's going to come with that, because it's not an easy process. And as we talked to Dion about her process, and her journey with lung cancer, we got to understand that if she doesn't go back, if she's not diligent and going through, then she doesn't get through to the other side of being a survivor. So with that being said, I'm climbing off my soapbox. I'm going back to you, Dr. Redcamp. So how do lung cancer patients know if they are candidates for targeted therapies?
So I think this is incredibly important. And there's also, so in 2022, we now have 9 different targets, which is kind of saying that lung cancer is not one disease, but 9 or more diseases that the FDA has approved drugs that can treat these targets. And so at one point during my career, many years ago, there was basically 2 types of lung cancer that we understood, and we tried to treat by the way the cells looked under the microscope. They were either large cells or smaller cells, and that's it. Pretty basic. But now with the human genome and understanding how genetics work, so there's genetics that you pass along, and then there's actually also genes that cause cancer growth. And that's what we're talking about here. So they're not always genes that you pass along from family member to family member, but genes that cause abnormalities in your own cells that cause growth and tumor growth and progression. And so in lung cancer, there are at least 9 different kinds. And so it is incredibly important to do testing and what we call comprehensive testing or next generation sequencing, genomic testing. There are lots of words for it, but understanding the genes that are causing the growth of the cancer is incredibly important in 2022 treating lung cancer. It's important even if you potentially have surgery and have a tumor taken out. Sometimes we use those genes to help us understand how to treat after surgery. And then for people who have later stage disease, it is essential and guides our therapy. And so everybody's tumor is treated differently. We know that not everybody gets tested, and there was a study that looked at patients who got tested, and the Black community got tested less often, which often meant also that they were less likely to be offered clinical trials that may be important to move their therapy forward. And I think we'll talk about that a little bit more later. But understanding that lung cancer is not one disease, but many diseases, and we need to understand the biology, which means genetic testing of the tumor. And that will help us understand how best to treat a very specific person's tumor. And so it's precision medicine for your tumor, and it gives you the right treatment to decrease the possibility that you may get treatments that are going to be less likely to help your tumor. And I think, again, hopefully we can get into Dion's story, because this is a great segue for the targeted therapy that she has been able to receive and hasn't had to receive chemotherapy. And so the evil word of chemotherapy that scares everyone, that may be helpful for some people, but some people don't need chemotherapy. They can get what we call targeted therapy for specific types of lung cancer.
Well, that was great. Look, Dr. Redcamp, you have a second career in broadcasting, because that was a nice move. A nice pivot and segue, as you said, to Dion. So let's meet Dion Smith. Dion, you're a lung cancer survivor. Please tell us about your journey as a patient of Dr. Redcamp and how targeted therapy helped you.
Okay. I was first diagnosed with lung cancer in 2007. And at that time, they gave me 2 years to live, and I didn't like that diagnosis. So I went to another hospital. I went to Duke, and there they said that, I I could live longer and I could live more than 2 years, but they would have to cut it out. So I had a right upper lobectomy, and they cut it out. I was a stage two. Yeah, I was stage two, and they cut it out, and my recovery was kind of long. It was about 6 months. I was on morphine, and I just couldn't take it anymore because that morphine wouldn't let me sleep. So, and it wasn't addressing the pain completely. So, I weaned myself off of it. I cold turkey, and after a month of no sleeping, I finally, leveled off. And then I got involved in cancer programs there in North Carolina. And from then, I was like, I did the programs every year. We planned them from year to year. But then in 2016, my thoracic oncologist said he saw something he'd been keeping an eye on. And so I said, well, okay, I don't want to make a decision now on doing anything. So I waited another year, and then they did a wedgeectomy and that was on my left lung. And so they took a wedge out, and they diagnosed it, and so there was nothing. It was nothing much. It was just it wasn't really there. They didn't give it a name or anything, but there was something, but they didn't give it a name. So I'm relocated from North Carolina to California. I came because my brother was sick. But in the meantime, I asked my oncologist to refer me to a treatment center here in California. So he sent me to City of Hope out in Duarte, and that's where I met Dr. Redcamp. And so she, examined me, and about 2 months after that, she put me on this drug, which is targeted therapy. So I didn't have to have any surgery. I just had to have this targeted therapy. And I was so excited because that surgery was a terrible surgery. It was really rough on me. And to think that there was a drug that I could take to keep this cancer at bay. And basically I've been doing pretty good, but there was another, I was on one medication, but then I didn't like it because I had to take it twice a day. So I decided I would like to change the medication. And it was okay, but then I think the dosage was too strong for me, and I was at risk of having organ problems. So Dr. Redcamp put me on a lower dose, but it was just as nasty. So now I'm back to my original medication that she put me on, and we'll see where it goes from there. But we have seen, she took a last scan of my brain and of my lungs, and it showed something that I might have cancer in my brain, but I'm believing that I don't have it. So we'll see what comes of that, you know. But other than that, my journey has been wonderful, if you can say wonderful for cancer. But I haven't suffered ever since that first surgery. I haven't suffered. So I'm pleased with that. And I think, go ahead. Go ahead.
Speaking to the brain piece, is that many of these drugs that are pills do have activity within the brain, and so in addition to avoiding things like surgery and chemotherapy, often we can avoid things like radiation, and so these targeted therapies can be very effective in the brain.
So, Dr. Redcamp, could you help us understand, because when we hear cancer and we hear chemotherapy, I think as a general populace, we tend to pair those two things together. You get cancer, you're supposed to have chemotherapy. Can you talk about that process of chemotherapy and why like targeted therapy is working better than the process of going through chemo?
So it's really about the right treatment for the right type of tumor. So like I said, it kind of precision medicine, precision therapy. And so it's saying, so Dion has a specific genetic abnormality in her tumor, and it's called ALK or ALK. And that's about 4% of lung cancers or of adenocarcinoma. Very small percentage, but that's why, because we know that biology, that specific treatment works exquisitely well. And so it's about understanding that cancer in general, and then lung cancer in general, is a group of diseases, and it can't be just one. So you need specialists who can help guide you through that. And it's about finding the right treatment for your cancer. Sometimes it will be chemotherapy, but not all chemotherapies. Most of the chemotherapies we have for lung cancer are relatively well tolerated. So different than breast cancer, where there are generally have a lot of side effects. In lung cancer, they have a lot less. Many people don't even lose their hair from the lung cancer chemotherapies we have. And so it's about precision treatment and getting the right treatment for your cancer. And so Dion has a story where her treatment is a targeted therapy with a specific ALK inhibitor, and others have things called EGFR. There's others called RET, R-E-T, or MET, M-E-T. And all of these have their own specific treatments. Again, many of them are targeted treatments. And knowing the biology helps us to improve survival, even for people who have later stage lung cancer, where it is spread. And so, and what we've seen is that survival, there's a new state of lung cancer that was published just yesterday. And we've seen that in the past decade, the even advanced lung cancer, the survival has increased by 10%, the 5-year survival. And it's not spectacular. It's at the 25% mark. So we still have a ways to go, but that used to be below 15%. So we are making strides in helping people live longer and then helping them live better because they're getting the right specific treatments for their tumors.
I want to say something. There are lung cancer survivor groups, and they're nationwide, and they have specific groups for like my type of cancer, the ALK, the ALK, or the EGRF, and all of that. And they are extremely helpful because all of the people that have the ALK, they, I find out what they're going through, what they went through, what they said to their doctors, what drugs they're on. And so we basically will know what we need to ask our doctor. And it really helps to have another group of people that are going through the same thing that you're going through. So I just wanted to say that. Yeah.
That's called advocacy for those. So now you have a peer group that y'all have a shared experience that that specific group can speak to, and then you all are sharing information now, and you're learning from each other, and you're able to take that information and go ask questions to your practitioner. So I think that's a wonderful thing to have available to you, because you realize that you're not alone out there. And that's going on. So I have a question for you, Dr. Redcamp or Dr. Gandahari later on, and it's more personal, so I'm going to push that to the back of the pile. But I was ask you this, Dion, since we got you talking. We talked about being Black as a risk factor, right? And we've listed between Dr. Gandahari and Dr. Redcamp about all of these number of things as to why. Some of them are just kind of societal. Some of it's provider bias. Some of it is based in the end user not following up. And then there's all of these other kind of intersectionality of all of these different things that cause being Black as a risk factor. How do we get more, and I know you can't wave a magic wand and solve this problem, but what are your thoughts in terms of how do we get more Black people to know more about lung cancer, recognize if there is some symptomology, and then engage in the system. Because what I heard from you when you're telling your story is you stayed engaged. You stayed engaged through surgery. You stayed engaged through having to go through chemo and uh, pain management therapy. You stayed engaged when you were moving across the country from North Carolina all the way to California, and you asked for a referral, and you stayed engaged when you got here. So how do we get Black people to stay engaged and lower that risk factor of being Black and lung cancer?
Well, I think you need to start a group or something. Have a group of survivors get together, so that there's some place that those people can get to. But I don't know exactly what you're asking. That's fine, because if you have a group, then the doctor can tell people about the group, and that's how they get connected and how we share information. But like, I tried to get a group started, but it didn't pick up, because I brought what I learned in North Carolina with me out here. But they're still doing it there, but we don't have one here. So I don't know exactly what to do about that. I hope I'm answering your question.
You are. You're absolutely right.
And the doctors can also refer, a patient to me, or anyone, to me. I don't know of anyone else who would be engaged. So often we have Cedars has a group of physical group that they have for people who have cancer, and we could do it through there, get a word out about a group from there. But I'm not exactly sure how to navigate that, but that would be my idea.
Yeah, I think you're right. I think if we could get, it sounds like what you're saying is if we could get Black patients, once they get identified as having lung cancer, get them immediately connected to a group, that would probably increase the chances of them staying connected with services and increase their chances of survival, because they have now that shared experience that they can lean into and ask questions that are safer, right? Because speaking as on the patient side of the fence, sometimes you're not as comfortable asking questions to your primary care provider, even though you should feel comfortable doing that. You don't always feel that way. But if you have a group of similar individuals where you all share uh, this condition, then you might feel more apt to ask those questions in that group. And then somebody, even if they can't answer, you could talk about it, and then that might make you feel stronger to talk to your provider about it. Dr. Gandahari, I see you shaking your head. You want to add something there?
Yeah, thank you. Dion, that's an excellent suggestion to really keep the community engaged and really pass on a message of support and hope, similar to other, like, for instance, breast cancer survivors are very strong in this space, and they support each other through the whole process. And feeling that, once you're diagnosed, you're not alone. You have this whole army of people around you that can help you. I think it's a very important and strong message, and really appreciate the suggestion that you have. I just want to take it to another step, was sort of going back to the just talking about it, and as far as screening and diagnosis. I think the key thing is just really being open about your risk. It's not a shame that if someone has smoked, and there is a lot of stigma that still surrounds the issue of smoking, and we as a community, as a society, as providers, as patients, we need to move away from that, because we know that if appropriate information is shared, that then the risk is identified, and the person becomes qualified for a screening. And so many times patients go to their primary care doctor, the doctor asks them, do you smoke? And they say no, and then the conversation is done. Whereas the next, you actually have to be proactive about saying, well, I used to, I don't
Yeah.
anymore.
Yeah.
Or that I used to smoke this much, and I'm only smoking this much, to really give an accurate information to the doctors, to the providers, so that they can help guide whether or not screening is appropriate or is an option. And then on top of it, it is never too late to quit. It's never too late to get help. And even a person who has been diagnosed with lung cancer, we know outcomes are better if one were to quit at any point in time. And we know the risk goes down from the point of time when a person has quit in terms of lung cancer. And if you know someone who is smoking or have a history of smoking, you have a loved one who's not listening to this, but you know about them, talk to them about, go ask a doctor about lung cancer screening. Just bring it up. Just have a conversation. We as doctors are the way that it's set up is that I cannot just order a CT scan. I need to talk to you about it. I need to tell you what it means to go have a CT scan done, what it means to be evaluated for lung cancer, what are the results look like, and what are we going to do about it? What will be your option? And then together we will sit down and say, is based on what you think is expected, what you see as your quality of life, what you're willing to accept, is this a right choice for you? And then together that decision is moved forward. So you're, again, sitting in the driver's seat and deciding whether or not this is the right thing for you. And by being in that position, you empower yourself to be much ahead in terms of diagnosing, treatment options, and really being in control. And I think that's really important, that this message is taken across in terms of how we can address this, in particular in communities of color, that we need that support from everyone within the community to get the message out.
And I would just mention also that there's such a big stigma associated with lung cancer, that you hear the word lung cancer and you think it's untreatable and you think you caused it yourself. And first thing people are going to say to you is, I didn't know you smoked.
Right.
And that it blames you. The minute, it's somebody who has breast cancer, they don't say, oh, were you eating a high fat diet? Why did you do this to yourself? People just accept that people who have breasts get breast cancer. And so as Dion says, people who have lungs get lung cancer. And taking some of that stigma away to understand that anybody is at risk, and we can talk about it.
Well, I was going to say, I think especially if you're of a certain age, and I'm not going to say what that number is, but if you're of a certain age, smoking was really accepted at a certain point in this country. And it flipped, like in the 80s, it started to, the tide started to turn as all of the reports and stuff that they heard about the impact of cigarette smoking started getting released and started getting out. But prior to that, I would encourage you, if you didn't know that, like, go watch a movie from the 70s. Television shows, everybody, it was a cigarette. It was widely accepted, and just a part of life. Riding in car, we didn't know the impact of secondhand smoke. And so those people that are of a certain age, give yourself some grace. Today, now that we have the information, if you're smoking today, there are programs and ways to motion cessation programs that you can get involved in. But I do think that those programs have to think about it in a different standpoint. And what I mean by that is, we did a program a couple months ago on trying to get kids to stop smoking and vaping and all these different things. And what they found in their research is the addiction wasn't early physically, it was the mental, right? The coolest person that they knew smoked cigarettes. The person that they looked up to the most smoked cigarettes, and they wanted to emulate that person, or they worked in an industry where smoking was rampant, whether it was construction or wait staff, or working in a bar, things of that nature, where it was conducive for smoking, and you just kind of picked up that habit to, you're blending in with the people that you're around. And then over time, the addiction part kicked in. But we really have to kind of address those early signs of those early things that really start people smoking to slow that down. And now we're seeing, vaping and things going rampant in high schools and teenagers and things like that. So, but that's a whole nother program. We're here to talk about lung cancer. So, Dr. Redcamp, why was Dion a great candidate for targeted therapy?
So again, the important thing was doing the tumor testing. And so there was sufficient tumor because she had the tumor resected. And so we were able to take that tumor and then understand the biology. So the test that we do is usually a send out test or within the lab of the hospital. And it takes about 2 weeks to get that result back. But because she had very good doctors at Duke when they first took care of her, they understood the importance of getting that genetic testing and did that for her tumor. So when she came to us, we knew that this was a specific alteration that we could target. And for ALK specifically, there are about 5 different drugs that treat this type of lung cancer. And so as she talked about her journey and some of the side effects and some of the challenges, there are multiple different drugs that can be used to treat it. And so even if one has too many side effects or is too challenging, there are others to choose from. And so it's the specifics of her tumor that made this specific treatment the best treatment for her cancer. And we're seeing this ALK lung cancer has incredibly good survival rates, even when you aren't able to do surgery to take it out.
So we like to give, the full picture here. So we've been talking about targeted therapy being so positive. So are there any negatives to targeted therapies?
Well, so every treatment is a cancer treatment, and so there are side effects. And it's for targeted therapy, you're generally taking a pill. So you're generally taking it once or more than once a day. So you have to remember to take it. Because you're not getting it. Many of the chemotherapies and immunotherapy are infused. And so once it's in, and you don't have to make that decision. But with these pills, you have to make that decision every day to take that pill and do it. And there are side effects that you don't feel quite yourself every day. There's kind of a new normal, and maybe Dion can speak to that, what that feels like, but it's not quite that old self because it is an anti-cancer agent. And so there can be fatigue and muscle aches and constipation and other types of things that can be very discomforting, and you feel them a little bit every day. But the opposite side of side effects from cancer, which can cause all the symptoms we talked about before, fatigue and weight loss and cough and shortness of breath and pain, generally the side effects of the treatment are less. And then we do have immunotherapy for certain people too, that can be extremely helpful and use your own immune system to fight the cancer. That's an IV treatment usually, but it activates your own immune system against the lung cancer.
So Dion, what has been your experience? Is it negative? Are you having any side effects from the medication? I know you mentioned you just didn't like to take that first one twice a day, but what other side effects are you having?
Yeah, there's some side effects, but they're not the kind that you would expect. I mean, there's, not getting sick or anything like that. It might be a few muscle aches here, but then you have muscle aches anyway, because I was in a car accident. So I had muscle aches from that. So I don't ever know where my aches are coming from. That's funny, but it's true.
Yeah.
But it's okay. Like Dr. Redcamp said, the constipation, but I have it under control. So I know what I have to do. So I just go ahead and do it. Yeah.
So Dr. Redcamp, okay, we mentioned surgery earlier. I know we've been talking a lot about targeted therapies and new genomic kind of testing and therapies, but somebody might need to just get some surgery. So if surgery is required in a lung cancer case, or even if a patient needs to have part of their lung removed, what is that experience and the recovery like?
So, I mean, surgery is still, for many people, the best chance of curing the cancer. It is a local therapy, so the cancer has to be relatively localized. And surgeries are getting better and better. we're able to do on many tumors, they're able to do what they call minimally invasive surgeries, where they're going in with a scope, and they're often using robots to do some of the very technical techniques. And so sometimes it's just a few days in the hospital. But they are taking out a part of the lung, and so there can be compromise of lung function and scarring in there. Often, the lung does re-expand over time, and so much of the compromise of the lung function can be improved, but there can be longer-term effects, and sometimes there's pain. There's a lot of nerve endings in that chest, and so where they go in, as those nerve endings even start to reattach to each other, there can be pain in that area where the surgeon went in. And sometimes that can be for many, many months. And sometimes it is persistent kind of forever. And so so there are those issues, but it is often the best way to cure a lung cancer still to do surgery.
So, we're here, we're talking with Dr. Redcamp and Dr. Gandahari and Dion about lung cancer, and they are our wonderful friends in our partnership with Cedars Sinai. But unfortunately, even though Cedars Sinai is one of the top hospitals in the country, everybody can't go there. And we know that when you're diagnosed with cancer, you have to have a team. So what are those people that are on, what are the practitioners that are on that team that gets assembled if somebody's diagnosed with lung cancer?
So at the time of diagnosis, we're working with a large group of people. We start with our pulmonologist, like Dr. Gandahari. We need a radiologist to help review the images and potentially doing the biopsy by either the pulmonologist or the radiologist. We need a pathologist to read the slides and to make that determination, a molecular pathologist to read the genetic alteration information. A medical oncologist generally often is the quarterback once the diagnosis is made to help understand where targeted therapies, chemotherapy, immunotherapy may play a part, and often to help guide whether radiation and surgery may be a part of therapy. And then radiation oncology, often for local treatment with radiation, and our surgeons who are the local treatment for resecting the tumors. And sometimes even extra people, because a lung cancer diagnosis is, to me, like getting hit by a Mack truck. You get this diagnosis that nobody expects and understands that it's pretty serious. And so often we have help with our social workers and our chaplains and our rehab medicine people and our supportive care physicians. And all of these members of the team help the journey of lung cancer. And it's really a journey, and it's not one moment in time.
So, all right, I'm gonna speak. So Dr. Gandahari, Dr. Redcamp, I'm gonna speak directly to Black folks right here. Okay, I'm gonna make it in plain terms. There's a lot of people in your business. Okay, real talk. There's a lot of people that's gonna be in your business, but you got to be okay with that, right? And yeah, you know what I'm talking about. We don't like a lot of people being in our business. Just straight up. That's it. But that's a lot of people. You heard all the different groups of people. But the reality is this: you need that team working on your behalf to get through this. And Dion can speak to you had a team, and then you add more people by joining the group, the support group. So talk about your team, Dion, and then and how they were instrumental in helping you get through this process.
Well, they all work in concert together. I mean, it's in concert. I mean, I don't have a problem with that many people being involved because each one has a part, and that's for my good. And so right. I'm happy that they're there. That's all I can say.
Well, good. We were glad that they were there for you too. But you know what I'm talking about. So, all right, so I know as we wrap up, this hour's gone by really, really fast. But I would be remiss if I didn't ask about clinical trials, right? So that is a big, that's a kind of a hot buzzword right now in healthcare in general. But what role do clinical trials play in terms of helping the development of new treatments, expanding current treatments and making them better? And how important are they in treating lung cancer in general?
So I think they're incredibly important, and we wouldn't be here with the drugs that are treating Dion and things like immunotherapy, which have helped a large number of people, if there weren't clinical trials. And so the perception that the clinical trial is putting you out there as a guinea pig is pretty profound, but it's also an option for new treatments that can potentially extend and improve life. And so if we're doing the smart thing and looking at drugs that are kind of targeted to somebody's specific disease and helping to, like immunotherapy that uses your own immune system, we're moving things forward, pulling away from things like chemotherapy and potentially offering new treatments that may be beneficial. But when we're starting, we don't know that they're going to work. And so we have to do the trial to understand. If we know that it was going to work better, we would offer that up right away, but we don't know that. And so generally in a clinical trial, there has to be the idea that the standard of care may be better, or the treatment that you're getting may be better, and that trial is going to answer that question. And some people are not comfortable with that. And there are different types of trials. So there are phase 1 trials where we're learning about what the drug is, how it works, and what the side effects may be. Some people may not be comfortable with a trial that early on, but those drugs do end up, being in people like Dion that help people. Phase 2 generally is looking a little bit more at the efficacy and understanding how well it works. And sometimes it's compared to other drugs, sometimes it's by itself. And then a phase 3 trial is usually comparing something to what we call standard of care. So in there, we may use things that are like placebos, where people, it's kind of a buzzword, I don't want a placebo, but it's generally that you're getting standard treatment no matter what. You're not being withheld. Treatment's not being withheld in any way. Those are old school things that we have learned from, and that's not what happens in trials anymore. But what can happen is that you're getting a standard of care treatment, and then you add a drug to the standard of care, and so some group are getting an extra drug, and some group is just getting the standard of care, and that's generally how those work. But having that discussion and being, I would say, curious about it. Not accepting it just at face value, but getting information and being curious about it, and knowing that there are drugs out there that are helping people to live longer, that have gone through that clinical trial process. And those people that were able and courageous enough to go onto those trials benefited from that. And Dion is benefiting from those people who came before her.
Yeah, and I just want to reiterate, thank you for that, Dr. Redkamp, first and foremost. But I do want to reiterate to our audience that, particularly in cancer clinical trials, you're going to get the standard of care. There's not just going to be a placebo. You're going to get the standard of care, and then potentially they're going to add something new on top of that. The beautiful thing is that being part of a clinical trial, you're going to get constantly monitored. All of these, the trials are at no charge to you, no additional charge to your insurance or to you out of pocket. It's just, they just want your participation because they need that feedback from you about this treatment or medication or whatever they're adding to the standard of care. And so it's wonderful, and you really get this great monitoring, and you get the whole team. Really, you get an additional team, which is the clinical trials team that are monitoring, and then you've got informed consent, and you can withdraw at any time, and all of those things make clinical trials much more safer and much more. And as Dr. Redkamp just stated, they are a necessary component to continue to advance care in any disease state. But we're talking about lung cancer tonight, so I just want to say, I got to keep banging that drum for clinical trials, and really, hopefully, we can get more people of color involved in clinical trials, so we can get that additional. Is there a difference in ethnicity and how a particular medication or a particular treatment is landing? And so we need to get involved. And I say my catchphrase for clinical trials is involvement improves outcomes. And so that's really what we have to look forward to. But I'm gonna sneak in my question here, and then we're gonna let y'all get out of here and get back to your day. All right. So My father was the 20 pack person, right, that you were talking about earlier, Dr. Gandahari. Smoked from Vietnam, and for about 40 plus years after Vietnam, maybe 50 years. He has stopped, but does that put me? But I've been around a lot of secondhand smoke as a child growing up. Does that put me in a risk factor, even though I haven't smoked myself? Outside of being black, am I in an increased risk factor because my father smoked?
Right. We look at a variety of different factors, including secondhand smoke, when we're seeing a patient who's concerned about lung cancer. And so we know that secondhand smoke adds an additional risk. It's not equivalent to you smoking yourself for as much as that, but that adds to as a factor. And the reality of it, there are other issues in the environment like pollution. We talked about radon as well, which it's maybe someone may be exposed to is actually like the second to tobacco smoke. That's actually a huge factor in lung cancer. And so if those factors keep adding up, yes, it does increase the risk factor. As it is now, though, when we talk about screening and what is recommended based on evidence, we only currently look at age and history of smoking, personal history of smoking, as the main qualifying factor. But if I have a patient that comes into my clinic and they have a family history, on top of it they also have secondhand smoke exposure or some other, I will consider them for evaluation, and I really will carefully look at their history to come up with it. And again, it's really important that we talked a lot about screening, but it's really important to be in tune with your body and recognize symptoms that Dr. Reckham earlier talked about. And many times when we have a history of smoking or been exposed to something and we have a cough, we blame it on it. And the reality of it is we should have explanation for a cough that doesn't go away. We should have explanation for an infection or a pneumonia that's not going away, that's not getting treated as quickly and properly, or other symptoms, and be really in tune with it so that we can evaluate it and go from there. So yes, in short, there is some slight increased risk, but at the moment is not at the point of screening category, but we just have to be in tune with your body and make sure that you're paying attention to every sign and symptom.
Okay. All right. So I feel better. Thank you so much for that. And I thank you all for indulging me in that brief moment, because I was like, I got some great experts here, so I'm going to ask the question. So thank you, Dr. Kandahari. And thank you also for our partners at Cedars Sinai for helping us put together this informative discussion. Thank you again to Dr. Gandahari, Dr. Reckamp, and our amazing survivor, Ms. Dion Smith, for joining us today. At the beginning of this program, I promised you a conversation that could possibly save your life, and I think we have delivered. Remember, as Dion said, if you have lungs, you can get lung cancer. Know your risk factors and symptoms and get screened. Remember that early detection saves lives. We'll be sharing resources in our chat, so please be sure to check those out. And you can also go to the Cedars Sinai pages, and they've got a wealth of resources, as well as we have resources on the blackdoctor.org website as well. So thank you all. So for our partners at Cedars Sinai and everybody here at blackdoctor.org, as well as our Daily Vitamina, thank you for joining us, and we will see you all next time.
Thank you.
Thank you.